Good afternoon. Thank you for inviting me to talk about this interesting topic. Now, we have done an own study in our hospital to look which could be the problems of medication in patients with liver cirrhosis. And you see, we looked at 400 patients, and these patients had, on the average, 5 drugs. There were some with 18 drugs, and when we gave strict criteria by an algorithm and looked which prescriptions were actually state-of-the-art and which not. And you see that 20% of the prescriptions were not correct. Either they were too high, according to this algorithm, or they were contraindicated. And importantly, the patients with such prescriptions, they were more likely to have an adverse drug reaction. They had a 5 times higher risk to have an adverse drug reaction, and they had also a prolongation of the hospitalization. So this seems to be something which is important. And the most important drugs which were causing these adverse reactions were the non-steroidals and psychomimetics. That means drugs used as antidepressants or neuroleptics. Now, one of the reasons may be that the pharmacokinetics is changed in a patient with liver cirrhosis. And what can be changed? It could be that bioavailability is changed. If anything, bioavailability of drugs would be increased. I come to that later. Also, the volume of distribution could be changed. This is a little bit difficult to understand, but the volume of distribution may be too high. And when it's too high, then the half-life of the drugs get longer. It's difficult to excrete. Excrete the drugs, and so we have a risk of toxicity. Hepatic metabolism may be decreased. We know exactly that this is the case, for instance, for the cytochromes. I come to that later. And also the elimination, of course, by the bile and also by the kidney may be impaired. At the end, we just have an increased risk of toxicity, as you have seen that in our patients. Now let's first go to the problem of bioavailability. And the problem of bioavailability is high for drugs that we call high extraction drugs. High extraction drug means these drugs are heavily extracted when they pass the first time across the liver. And the extraction rate should be more than 60%. And for these drugs, when you apply them orally, the bioavailability, which is low, since they are extracted already in the first passage, so the bioavailability is certainly below 40%, can go up to 100%. And that, of course, is a problem because patients may be overdosed. You see that here, when the liver doesn't work well, then we have less metabolism and we have a higher bioavailability. For these drugs, they are metabolized in the liver, as I told you. And of course, also the clearance, once the drug is in the circulation, also the clearance can be impaired. And the clearance for these drugs equals the blood flow across the liver. And the blood flow across the liver is mostly also impaired in patients with liver cirrhosis. So we have 2 things. When you apply these drugs intravenously, it's only the clearance you have to deal with, which is reduced. And when you give them orally, you have 2 things. You have bioavailability, which is increased, and the clearance, which is decreased. I give you an example of one of these drugs. This is propranolol. Propranolol has been mentioned already. And it's a non-cardioselective beta blocker, which is used as a bleeding prophylaxis in patients with portal hypertension. And we undertook this study, just recently published. You see here propranolol kinetics after intravenous application. You see that cirrhotic patients in dark and in white the normals, you see that the elimination is retarded, as I told you. This is the clearance. And when you look at the oral situation, then you see they reach much higher concentrations with propranolol, at least 2 times higher, and you see also the retardation in the elimination. When you quantify that, you see that bioavailability in a normal person is around 20%, and in patients it is as high between 80 and 100%. This is a problem. When you don't know that, and when you give the normal dose, these patients may decompensate. Which are these high extraction drugs? There are some drugs that you use in your daily praxis. You see beta blockers. These are the lipophilic beta blockers that you have. So I mentioned already propranolol, but it's also nebivolol, it's labetalol, and it's carvedilol. So the 2 beta blockers that we use in these patients to prevent bleeding are under these drugs. Then all calcium channel blockers, with the exception of amlodipine, have low bioavailabilities. And then I mentioned already the psychomimetics, the sedatives. I do not go over everything. Importantly, also opiates, morphine and others, but not oxycodone. And nitroglycerin, which is not used much anymore, I think, and sildenafil, importantly, and statins. Statins, I have to say, there is not much literature about statins in patients with liver cirrhosis. But statins have low bioavailabilities. They should act in the liver, and in patients with liver cirrhosis, it can be expected that they have higher bioavailabilities and they may cause muscle damage. Now let's have a closer look at the beta blockers. You see here I have listed and highlighted the bioavailabilities. Atenolol has a low bioavailability because of absorption. This is not a hepatic problem, but you see then the lipophilic ones. The lipophilic beta blockers, propranolol, carvedilol, nebivolol, with these low bioavailabilities, and they cause a problem. As Dr. Semela already told you, when you have a patient with liver cirrhosis and you want to prevent bleeding because of peripheral varices of the varices, and the patient has also heart failure, then it's good to use carvedilol, since you have the data for heart failure for carvedilol. You have also good data for prevention of bleeding, but when you use it, you have to use a low dose, a lower dose than I give here. This is the normal dose in normal patients, as you have been told by Dr. Semela. And the opposite are drugs, the so-called low extraction drugs. So they have a low hepatic extraction, they have high bioavailabilities, and when we look again at clearance, then the clearance is basically driven by the metabolic capacity of the liver to metabolize these drugs. And you see, when you look at the content of the cytochromes, which are the main enzymes metabolizing drugs in the liver, you see that in patients with cirrhosis, that they have a decrease in the content of these enzymes. So also here, the clearance is going to be a problem. It's going to be decreased, and but it's not the bioavailability. The bioavailability is already high and cannot be higher. The clinical consequence is that you can use an initial dose in the lower range of normal and then adapt the maintenance dose according to efficacy and toxicity. You see, the drugs that you use here are the ACE inhibitors and the ARBs. Let's have a closer look at these drugs, which are also interesting for hepatologists, not only for cardiologists or internists. You see, there is some reason to use ACE inhibitors also in patients with liver cirrhosis, because they can also decrease the portal pressure. You see that here in this meta-analysis published in the Journal of Hepatology. You see that the decrease in patients with child A class is in a similar range as compared to the beta blockers, the non-cardioselective beta blockers, and but there was no decrease in this meta-analysis in patients with child class B or C. There is also some indication that you could use the drugs to prevent liver fibrosis. But the important point for me here is the possible adverse events or adverse reactions. You see that here, this was published already 30 years ago in The Lancet. They published, it's an Australian publication, they published 4 patients who decompensated because of they were treated with an ACE inhibitor. Look at this patient here. So this patient had no captopril and then he was treated with a low dose, which was doubled with captopril. This is the plasma renin activity. You see that it is high. You have heard that already. They have an activated RAS. And it gets higher, this we would expect with captopril. And you see the excretion of aldosterone, which drops when you give captopril, which is expected. The patient had a drop in the blood pressure, which we would expect. But unfortunately, the patient also had a drop in the GFR. So the kidney was not functioning well because of the effect of the ACE inhibitors on the glomerular filtration. And you see that the patient had difficulties in excreting sodium. The patient decompensated by increasing the body weight. So it led to a further problem in excreting sodium. And this is what we see, especially in patients with child B or C cirrhosis when you give these drugs. So you have to pay attention there. One word about renal function. It's not only the problem of the liver, but also of the kidney. And you see the problem that we have is in estimating the creatinine clearance. You see that you have to understand that creatinine is synthesized in the liver. And in patients with liver cirrhosis, the synthesis of creatine is impaired. Patients with liver cirrhosis usually have a low muscle mass, so they have not only a low creatine synthesis, but also low creatine in skeletal muscle, and they convert less creatine into creatinine. And they also have an increased tubular secretion of creatinine. That means that patients with liver cirrhosis usually have low serum creatinine values. It can be very low. And the problem then you have when you use the Cockcroft formula to estimate the clearance, when this is too low, the clearance is overestimated. And you see that here in this publication. This is the estimation of the clearance of the GFR by the Cockcroft formula. In this patient, 100, which would be normal. And when you estimate the clearance with when you take 24-hour urine, then you are lower. And when you do the inulin clearance, so you estimate the real GFR, it is lower. It is again lower. So this is a problem that we have when we have to adapt medications to the renal function. What you should use is that, and you should be aware that this is still too high, and you should avoid to use the Cockcroft formula. At the end, still something about the NSAIDs. The NSAIDs, I think, are quite bad in patients with liver cirrhosis. You see that here from an old publication. We would expect that 500 milligrams of aspirin is impairing the renal excretion of PGE2, which is formed in the kidney. And this is the case in cirrhotics and in controls. And you see that controls have a lower adrenaline, noradrenaline concentrations than cirrhotics. You heard already this active circulation. And what we see here is the effect on the GFR. We have no effect in the controls, but we have a drop in the cirrhotics. And this is unfortunately what happens. So patients with ascites, cirrhosis and ascites, as you have heard already many times now, they have an activation of the sympathetic nervous system, of the RAS, and in order to keep open the renal vasculature, they are obliged to form PG2 in the kidney, and when you block that, then they undergo renal vasoconstriction and they may decompensate. You see that here in our study. 36 of the 400 patients that we looked at were treated with an NSAID, and 2/3 of these 36 patients had an adverse event. They had GI bleeding, they had more ascites, or they developed renal failure. So the conclusion would be that you should use only drugs that you know well, and with a favorable kinetics in patients with liver cirrhosis. Try to avoid the prescription of oral high extraction drugs. Sometimes you cannot avoid that. And then you just have to know what you do. Do not use serum creatinine or Cochrane formula to estimate the GFR. Avoid ACE inhibitors or ARBs in patients with decompensated cirrhosis. And don't use NSAIDs in patients with liver cirrhosis. Thank you for your attention.